38 years as an academician and as a clinician, and he also has a startup equity with GADA, mHEALTH, Diabetes Care, Pedios Food Solutions. I invite Dr. Shah. He will speak to us on what physios should know about diabetes. Dr. Shah, please.
To you as well.
Thank you, Dr. Vimal, for those kind words. I am in a good company of Dr. ARUN, MAIYA, who is going to focus extensively on diabetic foot. And in a company of Dr. MAIYA, I am going to enlighten you on the subject of diabetes. Diabetes is the second most researched subject currently after cancer. And there is an extensive research happening in diabetes. So I'm going to cover the area of give you an understanding on diabetes and what is pre-diabetes, give you an overview of diabetes care, issues, outline of treatment, followed by plenty of complications which happen in diabetic or they go hand in hand with uncontrolled diabetes. And in the end, I am going to focus partly on diabetes and bone health. I would not go in details about much on foot issues. Dr. MAIYA would address that. And then after my 20 minutes of talk, there would be surely many questions you will have, and I would try to answer at the end of my talk and after Dr. MAIYA finishes the question. So diabetes is interpreted as a disease of insulin deficiency. People have insulin resistance due to obesity. Juhi, can now the damage to the beta cells decides what kind of diabetes it is. Insulin resistance remains for the rest of the lifetime of a patient, while beta cell function would decline every year to the tune of 4%. It's a chronic, progressive, relentless, progressive condition, and it gives a challenge of control to the physicians. However expert doctor would be, patient repeatedly goes out of the control, and patient requires repeated change in the treatment. The major defect is in insulin secretion, which declines year after year. But the fasting hyperglycemia is being decided by liver. When the food is not consumed, the glucose is constantly produced for body's requirement in the liver, and that is called as hepatic glucose production. So patient produces glucose from liver through various biochemical pathways. The second defect is in the glucose utilization, which you can see on the right on the muscle side, which is called muscular defect, and there is a glucose uptake is defective in the muscles. Two enzymes which are responsible, one is called as glucokinase and the second is glycogen synthase. Responsible for glycogen synthesis is insulin dependent enzyme. And these two enzymes, when they do not function, patient would not have utilization of glucose. As a result, hyperglycemia would be persistent. Later on, we would see that now this three basic defect of diabetes has been expanded to 8 different pathophysiological defects. And this particularly depicts that there is excess deposition of fats into the different tissues. Primarily, an excess calories stored in the body as an adipose tissue is the energy storage organ. Subsequently, this excess fat is stored in the liver. That's what is called as a fatty liver, which is responsible for the insulin resistance. Similar fat deposition happens in skeletal muscle. There is intramyocellular lipid deposition, and there is also deposition of fat in islet cells of beta cells. That results into defective insulin secretion. This diagram shows that insulin resistance may be seen right at brain level, myocardial level, and in all other organs. But what complications you visualize and clinically you detect are primarily due to the vasculopathy, and we would address that in few minutes' time. The people who have insulin resistance in early years, you can see on the top, have some of the symptoms like fatigue, constant hunger, inability to lose weight, cravings for sugar, fatigue after the meals, various aches and pain, upper abdominal obesity. All these are features of insulin resistance prior to the development of diabetes. All this, many of these patients would have hormonal imbalance, lipid abnormality, and some of the women will have polycystic ovary right many years before the onset of diabetes. So these are the features of insulin resistance which decide that patient would develop diabetes after few years. Now, there is a stage which is prior to diabetes with just borderline glucose, which large majority of the doctors and patients tend to neglect. And what causes diabetes or pre-diabetes, you can very well see that obesity is extremely important risk factor in those families where there is history of diabetes are at higher risk of developing diabetes. Right in the early middle age of an individual, a sedentary lifestyle will predispose to a diabetes and pre-diabetes. There are also the markers which you can make out that these people would develop diabetes in future. One of them, very important, a physiotherapist might assess is fitness level. So low fitness is associated with future risk of diabetes. There is also an association with number of hours an individual sleeps. More than 9 hours and less than 7 hours are associated with diabetes. And over last 20 years with urbanization and with economic growth, people have changed their dietary habits. We are consuming more high calorie dense, high salt, high fat kind of a food. People consume sugary and liquid empty calories in plenty, which results into obesity and increased demand for insulin. And right from ancient Ayurveda, it has been said that when mind works more than the body, people develop diabetes. So all these risk factors commonly seen today are associated with diabetes, but in pre-diabetes stage, people can prevent and postpone diabetes by 5 years. This particular research, diabetes prevention program in USA, proved that with intensive lifestyle, the risk of diabetes could be reduced by 58%, and it was controlled compared with metformin usage where the risk was reduced by 30% compared to a placebo group. This lifestyle included 150 minutes of modest exercise per week. No big exercise program was advocated in this particular trial, but most important was 7% body weight loss was to be achieved. So please focus in diabetic people that weight loss must be achieved, which can be coupled based on individual's ability to exercise, pick up whatever exercise program along with diet to lose 7% body weight. And that results into prevention of diabetes. Let's focus on the diabetes part of it. There are challenges in managing a diabetic when a new diagnosed diabetic looks at the report. He has to accept the diagnosis. He is into denial and he thought he would never get diabetes. Now he has been asked to change his habits. He has to develop skills and abilities to manage and decide on choosing healthy food and eating regularly on time in the suggested dietary pattern and particular recommendations. He's supposed to manage exercise routines, what he can take it at what time of the day. We know that people are extremely busy into various things, into difficult travel in the city of Mumbai, and exercise is not a priority for most of the people. How to fit exercise time is difficult. To find the facility to exercise is challenging. And at the same time, there are demands on lifestyle, but there are always fluctuating blood glucose. There are plenty of medications doctor has prescribed for various comorbid conditions, associated condition, and associated symptoms. Patient has to live with side effects and with fear of complications in the future. With this kind of a program and recommendation. On the other side, if you look at from the physician's aspects, they look at diabetes as a very mild disease during first 5 years of life in a patient, where a couple of tablets prescribed will always control the patient. But it is becoming very, very difficult when 5 years are over. In large majority, 5 years get over by the age of 50. And once the 10 years are over, it becomes extremely difficult. People come close to the need for insulin. Most patients in their lifetime of diabetes, in spite of knowing, are unable to lose weight. So they have to manage with that kind of a weight and associated morbidity of obesity. Many of diabetics, it is seen in many studies that they are stressed. Depression is very common in diabetic people. There are all kinds of distress, and all this in later life leads to cognitive impairment, which is much higher in diabetic population compared to healthy control population. There is frequently non-adherence to multifaceted treatment, insulin program, and multiple monitoring which is required. Now, it is well proven that in the first couple of years, if a patient is aggressively managed and achieves a perfect glycemic control where HbA1c is 6.5, 10 years down the line, there is a benefit. This is called as metabolic memory, and that helps in a long-term control of a patient. Now, these are all challenges to a nutritionist, challenges to healthcare team, and challenges to diabetes counselor and educator. He or she has to get patient to follow the diet, reduce calories by 500 to 750 calories, teach him on how to manage exact quantum of food, understand about low glycemic index food, try to achieve less amount of carbohydrate, as close to 50%. Currently, diabetic patients are eating 70% calories from carb. They have to come to 50% calories from carb. They are asked to increase protein intake from 10% to 25% and reduce the fat intake. The most important and a difficult challenge is to lose weight by more than 5%, and this is to be achieved with high intensity lifestyle intervention. There are many studies which have proven that a very low calorie diet, less than 800 calories per day, many times using a meal replacement formula, would result into significant weight loss, as high as 15% weight loss. If I show you a particular trial published 2-3 years back, this is called a direct trial carried out in a primary care practice in United Kingdom. But in early years of diabetes with duration less than 6 years, all patients were initial 2 months given 835 calorie meal replacement diet. No solid food, no particular food. In many people, this resulted into reducing 1000 calories per day. 87% of patients who achieved 15 kg weight loss at the end of 1 year, their diabetes was in remission. This is as good as diabetes is being cured. Some of the patients achieved the result similar to bariatric surgery. This is a clear example that weight loss can be achieved with an intensive diet-related program. There are many diet programs like paleo diet, Mediterranean diet, intermittent fasting. We would not go into the details of any of this diet, but none of this weight loss can be maintained unless an individual maintains 30 minutes minimum of exercise per day. So regular exercise is very necessary. It is must to maintain the weight loss. So weight loss is important, but it is very difficult. This is the relationship between physical activity and maintenance of weight loss. You can see that people who did not maintain physical activity could not maintain the weight loss. And coming to an ominous octet, there are different 8 pathophysiologic mechanisms currently have been identified as causative for diabetes, and there are 6 different classes of oral medication. We select not sequential therapy as per the practice in past. We try to select and make a combination therapy addressing multiple different pathophysiologic mechanisms, and that results into better control. When people do not have endogenous insulin, large majority of the patients still need insulin because longevity has increased in diabetic people, and after 15 to 20 years of diabetes, not many people are controlled on oral medication and they require insulin. To give you an idea about multiple medication, metformin is the mainstay in all diabetic people. Unless contraindicated, metformin must be used in all diabetic people. A cheap drug affects liver, adipose tissue, and skeletal muscle. It's a metabolic activator, and effect of metformin is exactly like what exercise does in the body. It is also seen as an anti-cancer agent, and it is under evaluation in many studies. It's an anti-aging agent as well as it has anti-cardiovascular disease. So the profile of drug is excellent. The drug increases GLP-1 secretion. Metformin modifies gut microbiota favorably. So metformin is an important drug for every diabetic. I would not go into the details of any other drugs. There are 5 different classes of agent which are listed here on this slide, and we create a combination. The order in which the drugs are selected are different with different physicians and based on the patient profile, but we create a multiple combination and try to delay insulin, which is many times not necessary to delay the insulin. The polypharmacy would result into increased adverse event, frequently hypoglycemia, and sub-drug-drug interaction. But these are the issues for physicians. As a physiotherapist, you don't have to worry. There is a class of GLP-1 receptor agonists, which are a new class of agent, very expensive drug injected once a week, excellent efficacy, most potent than all oral medication, cardioprotective. They can achieve anywhere from 5 to 10 kg weight loss and no hypoglycemia. Extremely important drug. Short acting, long acting, and pre-mixed insulins are available. We would not go into the details of insulin, but they are underutilized. And please remember that all insulin treated patients are at extremely high risk of hypoglycemia. When there is a peak insulin action in many patients, you would not know they have a peak insulin action in this particular time zone. At that time, if they are subjected to exercise, their glucose utilization will improve, it will increase, and they would be susceptible to hypoglycemia. So prior to any exercise in insulin treated subjects, we recommend that they should always consume 100 calorie snacks prior to beginning of exercise. People should always carry a small quantity of high dense sugar based item in their pocket, that if there is hypoglycemia at any stage, they can consume either glucose or energy dense carbohydrate. So it is very, very important when they visit physiotherapy center to check at what time they injected insulin. You will not know, patient might have injected pre-mixed insulin, which might create hypoglycemia. So hypoglycemia is a barrier in many people. We would not go into the detail, but diabetes is defined as a vascular disease. In many people, the vascular complications start early And if you see the complication incidence here, you can see that after longer duration of diabetes with increasing age, many patients have retinopathy and nephropathy. 50 to 80% of patients have a peripheral neuropathy. 30 to 40% of patients have cardiovascular disease or peripheral vascular disease. If you analyze all these complications, retinopathy and nephropathy are microvasculature. So they are called as small vessel disease, while a stroke, coronary and peripheral vascular disease are macrovascular complications. And if we look at the incidence of cardiovascular disease, almost 2/3 of the diabetics in their lifetime will suffer from cardiovascular disease. Stroke risk is 2 to 4-fold higher. So is a coronary heart death, as well as heart failure is very common in diabetic people. If we look at what is seen in aging, is seen in diabetic people. Diabetic people age much early. They have fatigability, muscle weakness, reduced endurance capacity, and sarcopenia a decade earlier than healthy population. They are physically less active. They have low energy expenditure. They are abdominal or visceral obesity or centrally obese, and they have associated hypertension, lipid disorder, and many vascular disorders. So it is like a diabetic patient is like 10 years more elder by their vascular aging. If they are obese, they have associated obesity related medical complication in pulmonary system. They have fatty liver, they have a gallbladder disease. Younger people premenopausal have PCOD, and these many disease including cancer risk is very high in diabetic people, similar to obese individual. Going further into the stroke, stroke is similar like any other stroke. There is no difference. Only thing, diabetic people are at increased risk of ischemic stroke. I would not go into the details of neuropathy. I hope Dr. ARUN MAIYA would cover, but sensory neuropathy is seen in more than half of diabetic people, and one can always test very easily for light touch and vibration with tuning fork or 10-gram monofilament, or in a sophisticated way with a vibration perception threshold can be quantitated with a small device. All this would identify a diabetic neuropathy. In many people with diabetic neuropathy, they could have autonomic neuropathy, and some of these people will have a postural drop in blood pressure. This is called as orthostatic hypotension. When they get up from the bed, their systolic blood pressure could drop by 20 millimeter, and this result into syncopal attack. But this is also a marker of autonomic neuropathy, and these people are at extremely high risk of cardiovascular mortality and cardiovascular death. Many diabetic people do not get any symptoms of myocardial infarction. Their heart rate would not change in response to an exercise. This is what is cardiac autonomic neuropathy. Again, time will not permit me to go into the details of many things. These are the foot problems which come in the way of delay in the healing in diabetic people. Sensory neuropathy, peripheral ischemia, autonomic neuropathy has an impact on the skin, sweating, skin texture, healing power of collagen tissue. Foot deformity, kind of footwear, trauma, injury and infection in the toes, and a habit of smoking. All these would affect an outcome from diabetic foot, and probably all these foot deformities would be taken care of. I am sure all of you are very, very familiar because you examine these patients closely when they visit your center, and all require specific kind of a treatment. Trauma in a painless foot is very, very common. The reasons are many. Again, I would not go in the detail. The slide is there, so I have put up here. Now I will take you into the slide detail in relation to adiposity. Most of the diabetics have increased fat tissue. We call it adipose. And this adipose has multiple association. Earlier we called it as an energy storage, but it has a link with immune system. You are sure that there is a subclinical inflammation happening in obese people. They produce higher quantity of TNF-alpha and interleukin-6. Adipocyte has an effect, and there is an association with cancer biology, and they are at increased risk of high cancer. They have an association with vasculature and acute phase reactant. So obesity in a way is linked with multiple systems in the body, but I would focus in next 5 minutes on impact of diabetes and obesity on bone health. So obesity has a negative impact on bone health. People who are uncontrolled have glucose going in the urine, which increases calcium excretion in the urine. Insulin is in physiology anabolic on bone formation, and a deficiency of insulin associated with low IGF would result into inhibition of bone formation, and large majority of obese diabetic people have vitamin D deficiency. So this is an association of different BMI and vitamin D level. All overweight people require a larger quantity of vitamin D replacement, and low vitamin D is associated with future risk of osteosarcopenia. You can see the factors which affect the muscle mass, which is sarcopenia, and a bone mass, which is osteopenia. Both are commonly seen in diabetic people, and what affects them are increasing age, subclinical inflammation, not a visible inflammation, vitamin D deficiency, uncontrolled diabetes, physical and inactivity associated with sedentary diabetic people, people who need in addition corticosteroid for various comorbid conditions. Some of these people have genetic susceptibility for low bone mass and a fatty infiltration into bone and muscle. All would result into reduced bone strength, reduced muscle strength, which would make a patient susceptible to fall and future risk of a fracture. Once they have developed a fracture, they will take a longer time to recover out of this fracture. And I would take you into further molecular mechanisms of how chronic hyperglycemia can affect metabolism and maturation of osteoblast by altering the gene expression. In uncontrolled diabetes, there is increased amount of pro-inflammatory cytokine which mediate osteoblast death. So they will not have new bone formation. There is an increase in rank expression which mediates the osteoclastogenesis. So there would be increased osteoclast which would result into clearing of a bone and result into lower bone mass. Advanced glycated end products are various proteins in the body are glycated due to persistent hyperglycemia. They are called advanced glycated end products. They interact with various proteins in the body. So they would cross-link with collagen fiber in trabecular and cortical bone. They will also link with collagen fiber in the skin, resulting into poor skin growth when there is a non-healing ulcer.
This, Dr. Shah, can I interrupt? Can you just speed up a little? We are short of time.
Yeah, in just last 2 minutes, how much exercise, what type, aerobics, resistance, amount of weight loss, reduction in A1C, all these are extremely important. During the period of lockdown, when people can't do walk or gymming, the concept is energy expenditure. People have to move larger joints, repetitive, with or without resistance. You all are exercise trainers, and you know that you can train the people to carry out various exercise at home level. Pre-diabetic people right in the second and fourth decade, 20 to 40, reproductive age women with PCOS, in a recent paper showed decreased lean body mass and bone mineral density. This is simply because the bone marrow stem cell has two pathways to become osteoblast or adipocyte. So the want signaling in diabetic people or obese people would be lacking, and there won't be osteoblast formation. they will make more adipocyte and they will become adipose. So there would be multi-cross organ talk between bone and peripheral tissue, a 2 decade before people become diabetic. This is being driven by insulin growth factor, and the time would not permit into going into the details of that. Recently, I heard Dr. Snigdha Mehta's lecture on exercise improving gut microbiota. There is extensive research happening between gut microbiota, obesity, and diabetes, and all kind of drug and non-drug interventions are necessary. And there are multiple molecular pathways which decide the gut microbiota affecting cardiovascular disease and diabetes. Finally, in telemedicine and in lockdown condition of corona, there is going to be in future all kind of devices which will do monitoring of a patient, and patient could be managed from remote, all telecommunication and artificial intelligence. With this, I would stop here. Thank you for patient hearing.
Thank you so much, Dr. Shah. Thank you for enlightening us. I think the take-home message that we take from Dr. Shah's lecture, very important about the link between obesity and diabetes, and the very important role of exercise, prescription and exercise for remission of diabetes, as well as for, besides its physical fitness value, and while giving exercises to keep in mind if patients are on insulin or not on insulin, how to mitigate any hypoglycemic crisis, to give the patient some snack just before starting exercises, keeping in mind, so having taken a history of the patient, whether they are on insulin or non-insulin before we start, are very important factors. Also, the importance of diet, and very important message he has given us that from a study where he showed that giving metformin and exercise, that how exercise, so as exercise as a drug-free approach, how it can reduce the glucose levels and the diabetes also. Thank you so much, Dr. Shah. We'll come back to you during the question answer session. I now invite Dr. ARUN MAIYA. Dr. ARUN MAIYA is someone very much a physio amongst us. He has done his Ph.D. on diabetic foot care. He is the Professor and Dean, Chief Center for Diabetic Foot Care and Research at the Department of Physiotherapy, Manipal. His areas of interest, of course, includes diabetic foot and cardiovascular conditions. His area of research is lots into diabetes, cancer rehabilitation, occupational health, chronic pain. His professional organization is he's the president of the Indian Podiatry Association, Karnataka chapter, and the membership director, World Association of Photo Biomodulation Therapy, and life member of various associations. He has various copyrights and patents. His research experience, he has over 150 publications and reputed journals. He has attracted various national and international grants and headed various projects, national and international projects. And he has supervised over 15 PhD students and currently is having 6 students. It's a very short biodata of him. I've not read out many. I hand on to Dr. MAIYA. Dr. MAIYA will be speaking to us on a very important topic on assessment and management of diabetic foot syndrome, a physiotherapy perspective. Dr. MAIYA, please.
Thank you, Dr. Vimal, Madam, for an excellent introduction. Am I audible to all of you? Today's topic of my presentation is diabetic foot syndrome, the assessment and the management from the rehabilitation point of view or the rehabilitation perspective. As all of us in the previous speaker, Dr. SANJIV SHAH, already highlighted about the the magnitude of the diabetes in India and its associated micro and the macrovascular complication. Among this, the diabetic foot syndrome, or commonly we call diabetic peripheral neuropathy, is one of the leading microvascular complications in diabetes mellitus. As a physiotherapist and also as a podiatry physiotherapy specialist, we study in detail about the biomechanics of both the lower extremity, upper extremity, or the entire body. It's important that we need to give a lot of importance in our clinical practice for the early screening of this diabetic foot syndrome, and it is important for a comprehensive management of the diabetes patients from the physiotherapy point of view. Understanding the complications associated with the type 2 diabetes, need for exercise-based rehabilitation, offloading tools, as well as what are the important rehabilitation strategies in the diabetic foot syndrome. The diabetic foot syndrome, earlier usually we used to call it as diabetic foot. However, now looking at the magnitude of its problem, or it's a multifaceted problem, it's a clinical trial of neuropathy, vascular, as well as structural changes leading to various complications. When we say the diabetic foot, predominantly in the clinical practice, we focus on assessing the neuropathy. However, the recent studies have established that along with the neuropathy, there are other two important systems gets affected in the diabetic foot. The most importantly, the vascular as well as the structural changes. When you say the neuropathy, the motor neuropathy or the sensory neuropathy or the autonomic neuropathy, sometimes the patients may manifest predominantly about 52 to 54% of the people manifest with the sensory neuropathy. The motor neuropathy is the second, and the next one is the autonomic neuropathy. Some patients may present with a combination of motor, sensory, and the autonomic neuropathy also. Why this is important is the long time association is to the complications related to the macro and the microvascular complication. Diabetic peripheral neuropathy is one of the major leading microvascular complications in diabetic patients. This prevalence is very high in type 2 diabetes as compared to the type 1 diabetes. And in the subsequent presentation, I will highlight only on our own published data in a reputed journal as the supporting document for all my presentations. If you look at the prevalence of foot complications in people with type 2 diabetes, in our Udupi district, a major community-based survey we conducted, we screened more than 1,20,000 people. We observed more than 24 to 49% of the people manifest with the various diabetic foot complications, starting from the autonomic related changes like fissures or the dry skin to the neuropathy like 49 to 54%. Why this is important is diabetic foot is the major complications of the diabetes, and once the patient diagnosed with the diabetes, most of the time they get hospitalized mainly because of managing the complications rather than managing the glycemic control. Even in the developed countries, the 25% of the diabetic admission is mainly for managing the complications, predominantly the foot complication. And according to the World Health Organization statistics as well as Lancet publications in 2005, every 32nd there is one amputations, or the people are losing their one of the structure of the lower extremity, mainly because of the diabetes mellitus. And in India, this is ranging from 20 to 32nd. In addition to the neuropathic or other complication, diabetic foot syndromes are also having an adverse effect on the fall. If you compare the neuropathic with the non-neuropathic people, the risk of fall is higher in diabetic peripheral neuropathic patient, mainly because of the decreased muscle strength, slow reaction, diminished sensory input, and this all mainly because of the peripheral neuropathy. And the fall risk is 52.6% higher in neuropathic patients as compared to the elderly non-diabetic or the non-neuropathic patient. This is very, very important because as a exercise specialist, in a day-to-day life, we deal with lot of patients with the diabetes or with the cardiovascular or with the other non-communicable disease patient. Most of the time, we ignore the neuropathic assessment in diabetes, and this is very, very important because even for a prescription of exercise, the foot assessment is very, very important. That can prevent lot of exercise-induced injuries or the complications. And also when we screen them thoroughly for the neuropathic as well as the fall, we can prevent various other associated complications. Normally, the patients with the diabetes or the diabetic foot present with three important chief complaint. It may be sometimes the majority of the people are asymptomatic because sometimes the sensory neuropathy, they may not even able to appreciate. When you examine only, you will come to know that what is the severity of the neuropathy. But according to the patient, they say, I don't have any pain or any other complications. Or sometimes the patients manifest with numbness, tingling, slipping of the chappal. That's the classical manifestations of the neuropathy. Whereas if the patients come with pain or pain on walking, commonly we call it claudication pain or resting pain or the nocturnal pain, it's mainly because of the ischemia. Then the next important point is the structural change. They can develop with the various deformities, most commonly hammer toe or the callus, or there is a loss of arch or reduced joint mobility, intrinsic clawing. These are all the common structural change we observe in the diabetes patient if they have a diabetic foot pathology. Whenever we assess the patient, even though I focus mainly on the diabetic foot assessment, this assessment is even very important when we are dealing with the patients with the type 2 diabetes mellitus. We need to focus on neuropathic assessment, vascular assessment, musculoskeletal assessment should focus on the limb length, girth, the strength, flexibility, intrinsic foot muscle assessment, and also the biomechanical assessment and the footwear assessment. Whenever we observe the patient, you can just for your understanding and to remember, always remember that look, listen, and feel. There are various 3 minutes diabetic foot assessment protocols or the programs are available across the globe. This is one important thing we always practice in our clinical practice. The first is always look for the clawing of the toe, callus, or the pressure area. Most commonly, the patients may develop this type of deformities, or if you look at the second picture, this is a classical observations for the charcot because there is a rocker bottom or there is a complete loss of the arch. Listen to the patient whether the patient says I have a numbness or whether I have a pain in the increase in the night or whether there is a tingling or whether the patient reports the pain on walking, or sometimes the patient also comes with the redness of the foot that you should not ignore because that is one of the warning sign for the cellulitis or other sort of infection that needs to be taken care before we go for any other physiotherapy approach. Then feel for plantar aspect of the foot. Always palpate and then see the soft and the hardness below the base of the great toe or the base of the hallux and the second metatarsal head. Commonly in the diabetic neuropathic patient, this is the commonly we see the neuropathic ulcer because in the early stage you can feel the hardness of the plantar fat. If this is ignored, later it develops the callus and then subsequently ulceration. So that a simple palpation of the base of the great metatarsal, second metatarsal head, as well as the great toe gives a lot of information about the structural change with the diabetic foot. Look for the cold feet, compare the pulse with the posterior tibial as well as the dorsalis pedis with the radial artery. Then also quickly perform the ankle pulse, compare the ankle pulse and then the dependent rubor or the atropic skin changes. This all usually indicates what type of the diabetic foot syndrome the patient is presenting. Then simple screening tool routinely we can follow in the clinical practice is the Michigan Neuropathy Screening Instrument. This have a both subjective and the objective component. Subjective component is there are 15 questions in that the patient, if the patient says yes to more than 8, that's a warning sign for the neuropathy. If it is more than 13, then there is a clinically established neuropathy. Then the next important point is related to the assessment of the protective sensation. Assessment of protective sensations in clinical practice, routinely we can perform this test. A 10 gram of monofilament, it is a very cost effective tool in all clinical setup. Whenever we deal with the diabetes patient, we need to perform this test. There are 5 important points can be identified in the plantar aspect of the foot, that 4 on the forefoot and the 1 on the heel. When you apply a 10 gram of pressure to this selected point, the patient needs to appreciate that sensation before the nail bend to the C shape. In case if the patient is not able to appreciate that sensation, then you can say that there is a loss of protective sensation. This is one of the warning sign for the sensory neuropathy. If this is lost in any one of the point, in the beginning itself, we need to take an appropriate measure to prevent the subsequent callus or the ulcer. There are the procedure we need to follow. I will not go into the detail. Like initially, we need to familiarize the patient by demonstrating that test on the dorsal or the palmar aspect of the hand. Then give a clear instructions to the patient. Close the eyes. When you perform the test, the patient needs to just raise the hand if they appreciate the sensation. The next one is called the semi-quantitative test. That's what Dr. Sanjeev sir also highlighted. The vibration sensation, vibratory sensation is also gets affected in the diabetes patient, because this is normally the peripheral neuropathy, both the large and the small myelinated fibers gets affected. The protective sensations and the vibratory sensations are the usually an indicator for the loss of large myelinated fibers. The advantage of this test is this is a semi-quantitative. Once again, the procedure remains same. If the patient is can able to appreciate the sensation or the vibratory sensation less than 15 volt, that is considered to be normal. But in the clinical practice, up to 20 volt is considered to be normal. If anyone having more than 20 volt of this vibratory sensation, then there is a loss of vibration. This is a second warning sign for the future complications of the ulcer. Why I am stressing this point is, if the patient is having a loss of protective sensation and the loss of vibratory sensation, if you are not taking a preventive measures like an appropriate footwear or appropriate foot education is not given, in the next 6 months to 1 year, they are prone for developing the neuropathic ulcer. This is what we are observing in our clinical practice. As I mentioned in the beginning, the burden of the diabetic peripheral neuropathy and the diabetic foot ulcer is very high in India, mainly because of the lack of awareness and the lack of early screening. The next important assessment is called the vascular assessment. This also can be performed in any simple clinical setup. Compare the pulse of the posterior tibial dorsalis pedis with the radial artery. Anything more than 8 changes is usually an important clinically relevant vascular change. In addition, we can also perform the ankle brachial index and the toe brachial index. Ankle brachial index, all of you know, it is the ratio of the systolic blood pressure of the calf region or the ankle and the arm. Normally, 1 to 1.29 is considered to be normal. Anything less than 0.9 is borderline. 0.9 to 0.4 is considered to be moderate to severe, mild to moderate. Anything less than 0.4 is considered to be severe peripheral vascular disease. If anything more than 1.3 is considered to be a non-compressible arteries or the macrovascular disease, because these two are important. Microvascular complications like the peripheral arterial disease, or the most commonly we call peripheral neuropathy, and macrovascular disease like the coronary artery disease or the stroke and other things I have already highlighted. These two are important complications even in the diabetes mellitus. Procedures is usually normally we conduct the Doppler study. We connect the probe to the connector, put the gel, and then slowly move the probe over the posterior tibial as well as the dorsalis pedis. And the systolic pressure is taken at the arm and the ankle. Basically, what we do is where the maximum Doppler sound hurts, that is considered to be the point of systolic pressure. Then This is important because in most of the patients with the diabetic peripheral neuropathy, there is a covert or the subclinical vascular changes. If you do the plain ankle brachial index, when you auscultate the vessel, you may not able to appreciate the sound. Therefore, the Doppler ankle brachial index is very, very important. The second important thing is the toe brachial index. The procedure remains same. It's only you measure the great toe pressure. This is important because, as I mentioned earlier, the microvascular changes are more common in the diabetes patient. Whereas the ankle brachial index may not be a true reflect, or it may not be a true indicator for the microvascular changes. Therefore, the toe brachial index, anything more than 5 in the clinical conditions or the clinical setup, we consider as a normal. Anything less than 0.5, even though we mentioned 0.7, but in the clinical practice, normally 0.5 and above is considered to be normal. Anything less than 0.5 is considered to be an indications for the peripheral arterial disease. Why this is important is, normally you see the calcification of the artery in the peripheral arterial disease and most commonly in the diabetes. When you do the ankle brachial index, sometimes you get a falsely elevated ankle brachial index. Therefore, it may not be a true indicator for either for the compressible or the microvascular findings. Therefore, the toe brachial index is one of the important investigations or the clinical assessment we need to do in the diabetic foot assessment. This is what in our study, one important findings we observed. We conducted the muscle ultrasound. It's a diagnostic ultrasound. What we observed is, even with the 1 year of duration of diabetes, the patients, along with the neuropathic changes, we observe the changes in the intrinsic foot muscle, plantar tissue changes, loss of plantar fat pad, as well as there is a decrease in the fascia. And also there is a decrease in the cross-sectional areas of the intrinsic foot muscle. Why this is important is, clinically when you observed only neuropathy. However, we did not find any changes in the structure. But when we performed the ultrasound, we observed that even with the uncontrolled blood sugar level, even with a 1 year of duration and above in the type 2 diabetes, we can observe an early changes in the structural changes. These structural changes are another predisposing factors for developing a foot ulcer along with the neuropathy. Therefore, biomechanical assessment is very, very important. Normally in the clinical practice, we can perform the static foot scanner and the dynamic foot scanner. All of us know, if you look at the weight bearing of the foot, when you stand, 49% takes by the heel and 5% by the arch, and then nearly 46% by the forefoot. But in diabetes patients, what happens is, because of the sensory neuropathy, they have an abnormal loading on the forefoot. This is one point, as I mentioned earlier, is the warning point or the warning sign for developing the neuropathic ulcer. So when we do the foot scanner, we will be able to understand how much is the load distributions, or the normally we call it as a plantar pressure distributions in the diabetic patient as compared to the non-diabetic patient. The red color indicates the high pressure point, and in the diabetic patients commonly we see an higher plantar pressure distributions in the forefoot. Suppose if they have a loss of arch, sometimes you can see the high arch or the loss of arch. Sometimes in the loss of arch patients, usually you will not be able to identify any of these points also. This is important in the clinically because whenever we observe the foot, especially we need to look whether the patient is having a normal arch, loss of arch, or the high arch. When the patient is having the high arch, intrinsic clawing with an abnormal distributions on the forefoot. This is, once again, I repeat this point, this is the important point for developing the neuropathic ulcer. Another important assessment we need to do is focusing on the gait analysis. Along with the plantar pressure distribution, gait analysis is important because it helps in identifying the various gait parameter, and this also helps in predicting the fall risk. And as I mentioned, the neuropathic patients are having a higher risk for fall as compared to the non-diabetic or the non-neuropathic patients. When we perform the biomechanical assessment of the normal gait, along with the gait parameter, we also look at the various change in the angle of the foot angle, knee angle, as well as the hip angle. This is important for us to develop an appropriate footwear. Once we complete this static, dynamic, and the biomechanical analysis, we identify the foot into the area of interest: rear foot, midfoot, forefoot, medial and the lateral, midfoot, medial, central, and the lateral forefoot, 5 metatarsals, and the hallux. These points needs to be closely observed. Accordingly, we need to provide and customized footwear to the patient. This is another study we conducted in our own center: foot kinetics and the kinematic profiles in the type 2 diabetes with peripheral neuropathy. There is a higher plantar pressure changes in diabetic with peripheral neuropathy as compared to the non-neuropathic patient. Then the next assessment is focusing on the footwear and the feet. The general hygiene of the feet should be assessed to stratify and minimize the risk of infection. Footwear is another important point. In most of the time clinical practice, diabetes patient, all of us, we are not even asking them to remove the footwear or the shoe. But any patient enters to your clinics with the diabetes, ensure that with just about 1 minute you spend time to look at their feet and also observe for the type of footwear they are wearing. Ill-fitting footwear is one of the common reason for developing the ulcer or the injury to the patient. So that appropriate footwear, the correct footwear is an important prescription needs to be given to the patients with the diabetes or with the diabetic foot. This helps in reducing the majority of the future foot complications. Why I'm stressing this point is in our study, a cohort of our study observed that even with the high risk diabetic peripheral neuropathic patient, an appropriate foot education and the footwear prescription prevented the subsequent complications like callus or the ulcer development. We have been observing more than 100 patients from the last 4 years, high risk neuropathic patients from the last 4 years. They have not even developed a single ulcer or the callus because of an appropriate education and the proper footwear prescriptions. We can stratify the footwear according to our assessment, and then accordingly you call them for the review. No neuropathy once in a year, mild neuropathy once in 6 months, moderate neuropathy once in 3 to 6 months, and patients with the high risk neuropathy every 3 months. What we need to tell is, whenever normally they come to physician for the glycemic management once in 3 months. All high risk neuropathy people needs to visit the foot specialist every 3 months. We need to perform a review assessment to predict and also to identify the foot risk. Once we complete the assessment, it is important that the rehabilitation strategies. The first important thing is an education and the foot care, offloading, tools, pain management, exercise prescriptions, and management of foot ulcer. All this can be performed by the physiotherapist. As I mentioned, it is an important and needs to be an integral component of all physiotherapists' clinical practice. When you say the education, a simple education about not to, the education do not, what the patient should not do. Normally they wear like lotion between the toes may impose the infection. Walking barefoot, tight footwear, using chemical agents to remove corns, cutting corns in the callus by home remedy, and the lifestyle modification. These things needs to be sensitized to the patient. The next important thing is, I will say what not to do so that we can prevent a lot of complications. Customized insoles for reducing the plantar pressures in the diabetic foot syndrome. In our center, what we do is, we have an advanced tool to analyze the foot, scan the foot, and the molding the insole. That is called the foot balance. This is important because most of the time, the diabetes patients manifest with any of either the overpronated or the supinated foot. Our objective is to correct the foot by providing an appropriate insole or the footwear. What we need to do is, like as I mentioned, there may be a high arch, there may be a loss of arch, or there may be a deformities. So in clinical observations, it is important for us to assess these medial longitudinal arch. There are various tests are there. I will not go into the details about the Windlass mechanism or the first ray assessment. These all other biomechanical assessment we do in patients with the diabetic foot to assess the risk for the foot complications. What we do is the simple thing: the patients will be asked to stand barefoot on the transparent mirror on the foot balance. Analysis will be started based on their demographic and other information. Then the patients will be standing straight. Then we ask them to bend 45 degrees of knee, then standing with the toes up. With all this, we assess what is the change in the arch during different loading. Then accordingly, the data will be recorded, and then we will analyze that. After analysis, we can take an appropriate insole, and based on their individual patient's presentation, we can provide a customized insole. It will not take more than 1 minute to complete this process, and this is readily available so that the patients can either you can modify in the footwear or in the shoes also. Then the next important component is the neuropathic pain. In the diabetes patient, the 49% and above patients are always manifest with the neuropathic pain. This is a major challenge in the clinical practice, and most of the time the patients will be prescribed with the pregabalin or the antidepressant medication, mainly to control the neuropathic pain. However, the patients has their own side effects or other complications associated with the drug. What we observed is the patients, once they are on pregabalin, usually their fatigue level is more. Morning they are drowsy, they are physically inactive. That once again is a challenging for the endocrinologist or the physicians to manage the glycemic control. Therefore, the non-pharmacological approach is very, very important to manage the pain, neuropathic pain. We have a major database. We have compared the patients with the neuropathy on pregabalin or on antidepressant medication and without medication. We conducted a randomized control trial, and the laser, what we observed is clinically as well as with the biochemically, we observed these laser effect in terms of assessing the nitric oxide and all the other clinical parameters like assessing the vibration perception, patient reported measures like pain and other, and also the assessing the vascular assessment in terms of the toe brachial index. We have conducted a major randomized control trial, and we established that the laser therapy helps in improving the microcirculation. As I mentioned in the beginning, the diabetic foot syndrome, the most common problem in the neuropathy is altered microcirculation. The moment we correct the microcirculation, even though we may not able to regenerate the nerve, but we can able to improve the nerve function, and the symptoms will drastically come down. This is another tool we have developed in our own center, because sometimes the obese patients are not able to lie down for longer duration. We have developed our own laser shoe. It is called the laser shoe technology, basically to manage the patient neuropathic pain. The patient can sit and then keep. This is still it's an funded project. Still the work is going on. This all the various publications in a good journal in terms of the painful diabetic neuropathic pain.
Dr. MAIYA, we are...
Yeah.
Hello?
Another 5 minutes only, not more than that. Another 5 minutes. The next important component is the rehabilitation strategy. Pre-exercise evaluation is important. We need to assess for the cardiovascular and the peripheral vascular disease by performing various exercise tests. Either it may be a functional or the submaximal exercise test. Assessment of retinopathy and neuropathy is important, because in these patients, static exercise needs to be avoided. When the patient, if the patient is having peripheral neuropathic pain, appropriate footwear and the foot education needs to be provided during the exercise. And another important in this pandemic, COVID-19 history also needs to be taken, because that diabetes patients, even the majority of the research have established that comorbidities like diabetes, the patients, the risk of COVID-19 is very high. Screening can be done using the PARC questionnaires or the AAC or the ACSM pre-participation screening before we start the exercise. Or in case if you can't able to do the exercise, alternatively we can go for the physical activity measurement. Various tools are available like global physical activity questionnaires or other Stanford 7-day recall questionnaires. Various questionnaires are available to assess the physical activity profile of the participants. What important thing we need to consider when the exercise is factors exercising the exercise glucose metabolism, the physiological factors and the pharmacological factors. One is the status of the metabolic control, like the glycemic control. If the patient is having more than 250 blood sugar level, it is important for us to monitor this because one of the common complications may be a ketone release, exercise induced ketone, so that you need to be very cautious. The next important thing is the basic or the pre-fitness level of a patient, blood glucose level at the onset of the exercise, and then whether the patient is having any insulin resistance. All type 2 diabetes patient with or without obesity, one of the most common or the challenging problem is the insulin resistance. The next important factor is the type of insulin or the oral hypoglycemic agent, the site of insulin injection and the time of insulin injection. These factors are important for us. The most important factors, I'll just skip this because mainly insulin resistance can impair the glucose uptake. Thereby, this is one of the important factors or the limiting factors whenever the patient, the glycemic control, especially the glycemic control is challenging when there is an insulin resistance. What important exercise planning needs to be done is balance, motivation, exercise capability versus the type of exercise needed. Exercise needs to be in a 50 to 70% of the VO2 max, ranging from 20 to 60 minutes per day, minimum of 4 to 7 days per week. Most important thing is gradual progression and the monitoring of the blood glucose level. Exercise needs to be started after 1 hour of the medication, either it may be insulin or the oral hypoglycemic agent, or maximum before 3 hours. You should not prescribe the exercise during the peak action of the medication. That may be one of the common reasons for the exercise induced hypoglycemia. What we can suggest the patient is carbohydrate intake, any type of biscuit or other thing, 15 to 30 minutes before the exercise. Thereby, it prevents the hypoglycemic event. Any exercise component needs to be a warm-up, minimum of 10 minutes of warm-up, and the cool down is very, very essential. As an active cool down needs to be given in diabetes patient, and 20 to 60 minutes gradual progression of aerobic exercise prescription. In addition, flexibility needs to be included in every day. Resistance exercise training needs to be at least 2 to 3 sessions per week. This is the common prescriptions we give. Resistance, and not whenever you go for the resistance training, don't select the same group of muscles in each training. What we can do is few set of muscles can be selected, and that needs to be trained alternative day. In addition, balance exercise is another important thing. In this COVID-19 pandemic, exercise outside or gym is not possible, so that exercise at home or physical activity promotion at home can be enhanced by this type of exercise. Most importantly, a low intensity exercise to the major group of muscle. Even in our own studies have established that when you focus on training the proximal group of muscle, because one important thing is the insulin resistance leads to the or restrict the glucose uptake. The moment you start focusing on the larger group of muscle, this itself will enhance the better glucose uptake. Thereby, we can reduce the insulin resistance. This all the balance exercise can be done at the home. Intrinsic foot muscle exercise and physical activity using accelerometers or the simple method. Effect of exercise on the glycated hemoglobin. We have observed that exercise training helps in reducing the glycated hemoglobin level. And another thing, we have one more device. This is established as part of our ongoing research. A common device which consists of all the 4 tools, monofilament, VPT, hot and cold, and the infrared. In a single device, you can able to perform all the important diabetic foot assessment. This is another test. I will not go into the. Okay, this is one example. We treated, and the patient we were able to save the limb, and also the patient was immobilized for more than 1 year. Along with the laser, a graded exercise, appropriate foot educations, and the footwear, we were able to make the patient ambulant and completely. We were able to recover from the foot ulcer, as well as we prevented the amputation. Okay, this is the summary. Early screening is very, very essential in diabetic foot syndrome as well as the diabetes patient. Customized offloading is another important component. Exercise-based rehabilitation, improving the glycemic control, improve the quality of life and the overall function and the mobility. Physiotherapist needs to be an integral part of the comprehensive diabetes care in India. This all various achievement. Care for your feet as your face, or you will bury your feet before your face. This is the center, our center, and thank you all.
Thank you so much, Dr. MAIYA.
Thank you, ma'am.
Yes. Yeah, thank you so much. Thank you for your the last concluding slide was, I think it carried a lot of meaning. To care for the feet is so much important, and Dr. MAIYA gave us some very important points, right from assessment to prevention and management. The assessment side, he spoke of 3 important markers of look, listen, and feel. I think this very, very short, in a very short way, he has told us how to look for the different musculoskeletal problems, to listen to the patient's complaints or the symptoms, and feel for the different vascular and skin changes on the foot. I think these 3 words carry a lot of all the signs and symptomology. The importance of footwear, I think, has been very well stressed, that the need for footwear and the cause of footwear, which we very often neglect as actually the principal cause of different foot ulcers. And it is, and especially in India, where we are both barefoot walkers as well as feet, we use the same footwear wherever, and footwear is not given as much importance. And the importance for us before any exercise prescription to look at the foot, because a lot of our exercise are done on the foot in standing. And the need for customized footwear for the patients with diabetes, and for the need for redistribution of the forces, because finally pressure is force per unit area. So once we redistribute the force, the pressure on the foot and on the pinpoint pressure is avoided. Also, the need for balance training in the presence of sensory motor as well as visual disturbances becomes a very important part of our training. And what he said about use of large muscle groups to increase the glucose uptake, and the various criteria for exercise prescription, I think he gave us a lot in a small nutshell. Thank you so much, Dr. MAIYA. I think now I would like Dr. Shah and Dr. MAIYA for some of the questions which have been asked by the audience. One of the questions asked.
Vimal, 1 minute.
Yes. Sorry, but
yeah.
Dr. Deepak Kachalya would like to make an announcement.
Yeah, we have good evening, everyone. We have a general body meeting now, but since the quorum is not complete, this postponed for half an hour, and we will take it after the question answer session. Back to you, Vimal.
Oh, thank you, Dr. Deepak. So you give us time for some time for question answers. I thought I had to hurry with the questions. Okay. So there is this question asked to Dr. Shah by Sampada. is that there was a recent article in the US about metformin being cancerous and called back by the pharma companies. How true is this and what are your views? But this is a question by
it
Dr.
is.
Rajiv Joshi, sorry.
Yeah, just to clear the doubt, it is not the metformin which is cancerous. During the production of metformin, there is an impurity which gets incorporated into the formulation. It is not in every formulation which is present. It is called in short NMA, which was also seen in ranitidine last year. So this was what came in New York Times, and announcement in US was particularly of a one pharma company batch. It is not true with every metformin produced by every company. But the problem is more intense in India because there are 200 companies which make the product versus 5 companies which make for USA. So I know of certain brands which are marketed in India, and they have taken and analyzed that their brand does not contain. So whoever wants to solve the doubt, if they are taking or if they are suggesting to relative, they should check with their doctor that this metformin, what they are consuming, is without NMA. It is not metformin. It is a particular brand of metformin which contains NMA.
Okay. Thank you so much, sir. This is another question which I think both Dr. Shah and Dr. MAIYA could take, is that many patients complain of burning sensation of the feet. So what is the cause and how does one treat that?
Well, as Dr. MAIYA highlighted, and he could take it after I speak, when there is severe hyperglycemia, there could be a nerve dysfunction which could be transient, and there could be burning. This would reverse when the blood sugar is normalized. So there could be a reversible burning symptom, but any burning, numbness, pain, all could be interpreted as an early feature of sensory neuropathy, which would require an evaluation, which Dr. MAIYA highlighted. There are also many other reasons for such symptom due to vascular ischemia or due to calcium deficiency, due to ill-fitting footwear, and many other reasons, not necessarily only sensory neuropathy. Over to you, Dr. Arun.
Yes, madam. Yes, sir. This, most of the point you already covered, sir. That one could be due to the painful sensory neuropathy. Normally, whenever there is a partial demyelinations or the changes in the sensory nerves, that normally the patient present with this burning or the numbness. This is most commonly because of an abnormal blood sugar level or the poor glycemic control that leads to the damage to the sensory fibers of the nerve, peripheral nerve. So most of the time they present with the symmetrical presentation, and other cause could be due to, in addition to that, whatever sir mentioned, if there is a non-metabolic or the metabolic neuropathy like vitamin D or the vitamin B12 deficiency, also sometimes in diabetes patients can also manifest with both neuropathy related to the diabetes related or related to the B12 deficiency. So these are the possible reasons.
Another thing is that this burning sensation very often is complained that as a nocturnal burning. It's basically during the night. What could be if there's some diurnal variation in this?
Nocturnal sense could be due to the, sometimes most of the time it is related to the vascular. In case if they have a compromised blood supply, or if there is a atherosclerotic changes in the smaller blood vessels, usually the rest pain or the nocturnal pain is predominantly seen. But even in the peripheral neuropathy, sensory neuropathy also, sometimes the patient is, usually we call it as hypersensitivity. The patients, when they go for or in the night time, usually a small stimulus can also irritate their, or hypersensitivity can increases the pain. It could be due to a sensory neuropathy, painful neuropathy, or it could be due to the vascular related cause also.
Oh.
Sir, anything you would like to add, sir?
Dr. Shah, would you like to add anything on the?
No, it is
Sanjeev,
fine.
Sir,
We can go further. There may be more questions, no?
Okay. Dr. Shah and Dr. MAIYA both mentioned about the hypoglycemia, exercise-related hypoglycemia, and to eat a small snack prior to exercise, some containing carb. The question asked is there any tablet to be kept in the patient's pocket for hypoglycemia?
Glucose tablet.
Pardon?
Glucose tablet, which is 5-gram glucose, now available in Indian market.
Okay.
If not, people can carry 10 grams or 20 grams of glucose powder in a sealed polyethylene bag or into a small plastic container, which can be consumed immediately, followed by any other sweet items. Glucose is the fastest.
What would be the symptoms of hypoglycemia besides sweating? And if you could just tell our viewers what would be the signs and symptoms of hypoglycemia?
The list of symptoms include palpitation, sweating, sudden hunger, feeling giddy, feeling loss of energy. So these are half a dozen common symptoms, which are primarily adrenergic symptoms, which may be confused or with something else or a cardiac and everything. But one has to ask for how many hours you have not eaten any food. That would explain that if 3 hours, 4 hours, individual has not eaten. If person has taken food 1 hour, 2 hours prior, it is less likely to be hypo.
Okay.
Most common cause is insulin injection. So if people are on insulin, it's the commonest.
Thank you, sir. So another question asked is that, sir, you, Dr. Shah, you highlighted on obesity and diabetes. There's a question, what about people who are underweight? Diabetes and who are underweight.
Underweight diabetic are more likely to be insulinopenic and not insulin resistance. It is kind of a type 1 diabetic in younger age group. In older age group, it is called LADA, latent autoimmune diabetes. And they are also insulin requiring diabetic. They have lesser chance of cardiovascular complications. They behave differently. They require different drug, but long-term complications of diabetes are vascular in nature. So nephropathy, neuropathy, everything is common in both the conditions, type 1 as well as type 2.
Okay. Thank you.
Thin people will not have to manage diet that easily because they don't have to lose weight. They can eat a normal diet.
Yeah. Thank you, sir. Sir, another question. I think both Dr. Shah as well as Dr. MAIYA can take this. Is that what is the cause and solution for dry skin in diabetes? This is a question asked by Dr. Netra Nairi.
Anhidrosis. It is a neuropathy affecting the skin, primarily in the feet, autonomic neuropathy. And they require kind of a lotion and moisturizer in the feet. Dr. MAIYA.
Yes, sir. Yes, sir. Mainly, it is related to the autonomic neuropathy, dry skin or the fissures. Moisturizing is the best method by which they can prevent that.
So moisturizing with any cream or any oils that would you suggest?
Cream will be best. Usually, yeah, there are creams are available. Normally, we call it Diafoot cream or Foot Health. There are various types of creams are available that will maintain the skin in very healthy.
Another question is that what is the cause of excessive bleeding at the heel in healed ulcers even after 3 months of rest? This is from Dr. Valerian D'Souza.
Healed ulcer means it is there is a is the ulcer is completely healed, or what was the question? Is it possible to clear it?
The question is, what is the cause of excessive bleeding at the heel in healed ulcers even after 3 months of rest?
One could be due to it must have healed with an excessive callus or the scar. In neuropathic patients, it's usually in case if they walk barefoot, or usually even in the heel, the sensory neuropathy they are not able to appreciate. And healed ulcer, basically because of the repeated physical trauma, there could be a reason for the bleeding.
It's always trauma, and people could be on a blood thinner like aspirin, clopidogrel, which can make them slightly more susceptible. But it is triggered by trauma.
Fine. Sir, as another offshoot of the question is that if nocturnal pain is due to decreased vascularity, wouldn't elevated foot worsen it? Is this true? Would elevation of the foot at night?
Yeah, usually in any most of the time, the diabetic foot, the vascular, especially the arterial changes are more. So that anytime, whenever they elevate the foot, that will induce further ischemia, that will lead to the pain. We have to see whether the pain is mainly because of the venous or due to the arterial. If there is an arterial, usually elevations will cause us the pain, further increase in the pain. If it is related to the venous, the elevations will relieve the pain.
I think we have come to a conclusion for the question and answer session. I think Sampada, you can go ahead with the vote of thanks.
Before that, just shall I 1 minute, shall I?
Yes, sure, Doctor.
Yeah. I think on behalf of both the speaker, myself and Dr. SANJIV SHAH sir, we thank the physiotherapy private practitioner group of Mumbai. I heard it is one of the very vibrant group in Mumbai for inviting us to deliver this session. And it's a good opportunity for me to share a platform with one of the very renowned endocrinologists of the country. Thanks, sir. And also I thank Dr. Vimal Telang, Dr. Sangeeta, Dr. Saroj Madam, Dr. Deepak, and all the members of the PPG for inviting me to deliver a session. Thank you all.
Thank you, Dr.
Yeah, Sampada.
Well, friends, this brings us to the end of this wonderful webinar. On behalf of PPG, I would like to thank both the speakers, Dr. SANJIV SHAH and Dr. ARUN MAIYA, for their excellent presentations and for giving us such important insights into diabetes. I would also extend my gratitude to Dr. Vimal Telang, who from the beginning till the question answer session made sure that everything went smoothly. A heartfelt thanks to dear Julie, Dr. Sangeeta's daughter. She's our backbone for all technicalities, and without her, this webinar wouldn't be possible. And finally, a big thank you to Sangeeta ma'am and the entire PPG team for always being so supportive and ever inspiring. Thank you everybody for attending this webinar. Sangeeta ma'am, you can take it.
Yeah.
Thank you.
Thank you, Sampada. Thanks. I think now we have concluded our webinar.